Thanks for listening to the GOSH podcast, the Gynecologic Oncology Sharing Hub. We share real, evidence-based discussions on gynecologic cancers featuring stories from patients, survivors, researchers, and clinicians. Our podcast is produced and recorded on traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. It is produced by the Gynecologic Cancer Initiative, a BC-wide effort to advance research and care for gynecologic cancers.
Hello, everyone. My name is Sabrina, and I would like to welcome you back to another episode of our new segment on the GOSH podcast called Next Gen in 10, where we interview GCI trainee researchers. Today, we are joined by Dr. Dwayne Tucker, a researcher in pharmacoepidemiology and health outcomes at UBC in Vancouver and at the Arthritis Research Canada. His work focuses on the safety and effectiveness of medications in chronic disease populations, with particular attention to pregnancy and rheumatoid arthritis. During Dwayne's PhD at UBC, conducted in the Endometriosis and Pelvic Pain Laboratory and the Uterine Health Research Lab, he focused on predicting pain-related outcomes after endometriosis surgery. This work combined machine learning and clinical modeling to develop the Endometriosis Pain Index, a tool that is designed to support surgical decision-making in endometriosis care. In parallel, Dwayne conducted molecular pathology research linking common cancer-related mutations to endometriosis severity. Today, we will be discussing the results from Dwayne's dissertation and its significance. Welcome to the podcast, Dwayne.
Thank you. Thank you for having me. Happy to be here.
We were thinking we could start with a bit of a background, trying to understand your research topic as well as the gap that your research aims to fill.
Happy to. So my PhD research was focused on predicting pain outcomes in endometriosis. Now, endometriosis is defined as the presence of endometrium-like tissue that's growing outside the uterus, and that contributes to infertility, chronic pain, and as you can imagine, impaired quality of life. Now, surgery is a common treatment for endometriosis-related pain, but some individuals still experience unfavorable pain outcomes after surgery. In fact, a systematic review showed that approximately 12% of individuals experience no pain reduction after surgery. 20 to 38% experience persistent or recurrent pain. So there's some reduction in the pain, but the pain still exists. And up to 50% of those who undergo surgery ended up have to do a second surgery or additional surgeries within 5 years due to pain recurrence. So these numbers are truly alarming and really underscore the great need to understand pain heterogeneity in endometriosis and to personalize surgical treatment for endometriosis pain. And that's primarily what my research, the gap that my research primarily focused on closing.
Okay, and so to address this gap, what were your research questions or your objectives?
The very first question that we sought to answer was, can we identify reliable clinical predictors of pain outcomes in endometriosis and estimate the likelihood of someone having a poor pain-related quality of life after endometriosis surgery, and do this before surgery is performed so as to inform the pre-surgical decision-making process. Secondly are there molecular factors contributing to endometriosis burden and worse clinical outcomes that could help classify endometriosis patients?
Okay, very interesting. So how did you go about answering these questions, or what was your methodology?
Sure. Happy to talk about that. So before we get into methodology, I want to highlight the data, the quality of the data, or how important the data was in achieving these aims, because a huge gap in the literature before was that their endometriosis studies and collecting clinical variables weren't done in a very standardized manner before. So it made it quite difficult for us to identify reliable predictors. And so the data that we worked with came from different cohorts. The endometriosis and pelvic pain interdisciplinary cohort at the PC Women's Center for Pelvic Pain and Endometriosis. And this cohort involved new and referrals to the center who prospectively underwent surgery for pain. And one key factor, or one key characteristic for this cohort is that they underwent multi-dimensional pain phenotyping, so extensive pain mapping to characterize their pain and to essentially standardize the clinical variables that we're going to be examining. And they were examined before surgery, and obviously we also had follow-up up to 2 years after surgery. So this cohort was essentially I guess, curated to answer these questions specifically. And in terms of methodology or how we went about answering these specific research questions, our research objectives, we did this largely in two phases. First, examining clinical predictors, and the second phase being focused on biomarker predictors. So for the clinical predictors, we examine variables that were available before surgery, and we examine them for their relationship with poor pain-related quality of life after endometriosis surgery. And this outcome was determined by the Endometriosis Health Profile 30, or the EHP 30 questionnaire for short, which is an endometriosis-specific questionnaire that measures the impact of endometriosis pain on someone's daily functioning or daily life. And in examining these clinical predictors, we first shortlisted 7 variables that are also common in pelvic pain. So these are called pelvic pain comorbidities, and we examined them for their relationship with poor pain-related quality of life after surgery in a cohort of 444 participants. We then expanded this cohort to 650 participants and also expanded the repertoire of candidate predictors from 7 to 32 to develop a clinical prediction model that we employed machine learning to accomplish. Now, in the second phase, which is the biomarker predictors, we examined surgically excised tissues from endometriosis surgery, and they were stained and examined for PTEN and ARID1A loss, which are common mutations in cancers. But we examined for the relationship of PTEN and ARID1A loss in endometriosis patients without cancer, and we examine for markers of endometriosis severity and progression, such as surgical complexity or surgical times and worse pain outcomes after surgery.
Very interesting. It sounds very, very involved, very intense, many different methodologies being used.
Yeah, yes, it was quite the journey and very different methodologies as well. So it was quite the interesting journey, I would say.
Okay, and what did you find, or what were your most interesting findings?
Well, I would say first we had some success. I'll speak firstly about the clinical prediction model. We shortlisted 32 candidate predictors, and these were shortlisted based on conversations with gynecological experts in endometriosis and also based on the literature. And we ended up building the final prediction model, which we coined the Endometriosis Pain Index. And we showed that using 10 clinical variables that are available before surgery, we can reliably predict the probability of a poor pain-related quality of life after surgery. And we're excited because this model performs comparably to other notable clinical models in cardiology and oncology. And so it's exciting development for women's health and endometriosis in general. And for findings related to the molecular work that we did, we saw that PTEN loss was associated with higher endometriosis stage. more advanced endometriosis subtypes and more surgical complexity due to anatomical disruption. And this supports the rationale for more examination into the role of P10 in endometriosis progression and severity, and particularly as a potential candidate for a future molecular classification system for endometriosis. And beyond that, it strengthens the rationale for more molecular research into potential biomarkers in endometriosis for us to understand better what happens on the molecular level in endometriosis. What are the key drivers, and how do their presence connect to different outcomes in different patients?
Very interesting. So, for someone listening to this who might have endometriosis or someone caring for patients with endometriosis, how do your findings change the way that surgical decisions or expectations are getting discussed before surgery?
I think for patients and those who care for them, I think my findings encourage more open and realistic conversations before surgery. Sorry, surgery can be, like I mentioned before, very effective for many people, but pain outcomes can vary from person to person. And having that conversation up front about what surgery can and can't do help sets expectations, particularly for the patients. And tools like the Endometriosis Pain Index can support those decisions by providing an evidence-based way to talk about likely pain-related quality of life after surgery, so decisions feel more informed and shared rather than one size fits all. But it's also important to highlight that this particular tool is to supplement the surgical decision-making process and not to replace it or replace clinicians' input and intuition.
Yes, I think that's super interesting and a good point to highlight that it's a good supplement, but not to be used on its own. So I'm curious, what inspired you to focus your research on endometriosis?
It's a very good question. And I get that question a lot, actually, which I understand being a cisgendered man in women's health research. I like to say that it was serendipitous and that endometriosis research shows me it was a chance meeting with my PhD supervisor, well, my primary PhD supervisor, Dr. Paul Young, who's a gynecologist and scientist in endometriosis research. And I saw his passion, drive, and the impactful work he was doing in the space, and that piqued my interest. And I must admit that at the time where we met, I didn't know much about endometriosis, but I started to talk to friends and family about endometriosis, and was actually surprised at how many people I knew that were close to me who were suffering and dealing with the burden of endometriosis on a daily basis. And this was a major impetus for me delving into endometriosis research and working with Dr. Young to help drive like impact in an area that is under researched and underfunded.
Inspiring. Well, we're glad to have you in the women's health research field. It's an honor.
Thank you.
So you developed the Endometriosis Pain Index, which is to help predict pain-related quality of life after surgery. And you mentioned that the idea is that this can be used in conjunction with conversations between patients and their physicians. How are these decisions made usually before we had access to this tool? And how do you see it being used in real-world clinics?
Yeah, no, very good question. I'd like to say the tool isn't actually being used as yet. It's just on the brink of being published, it's being accepted, and I'm just reviewing the proofs. But I also want to make it clear that I am not a clinician. And so again, I see this tool as a support rather than a decision maker. And right now, surgical decisions are based on patient symptoms, medical history, and importantly, just conversations between patients and their gynecologist. And So the endometriosis pain index, like I said before, doesn't replace that process. It adds to it by providing an evidence-based estimate of pain-related quality of life after surgery, which can help inform the shared surgical decision-making in the clinic. And it's to be used at the discretion of the users, like I said, patient and clinicians together. And in any scenario, for example, if the model predicts that someone is likely to not benefit as well from surgery, the final decision is still dependent on the users and primarily the patient, and whether the harm or the potential harm outweighs the pros, or if the pros outweighs the potential harm. That decision is still with the patient and their healthcare provider.
Okay. Thank you for explaining that. So, one of the key messages of your work is that pain outcomes really aren't just about the surgery itself. What do you think that this tells us about how endometriosis should be treated more broadly?
Hmm. That's a good question. Again, I'm going to preface by saying that I'm not a surgeon or gynecologist, and so I think those treatment decisions primarily should be made by those people with those special credentials. So my approach comes from a research perspective. And what my work highlights is that pain in endometriosis is highly variable, and treatment needs to be tailored to the individual. Surgery is effective for many people, and that's important to emphasize. I'm not saying that surgery doesn't work, it's highly effective. But for some individuals, it may not be the most effective option at the given time. And so, where possible, evidence-based tools like the endometriosis pain index can help support that decision-making process about who is most likely to benefit from surgery and who may not, or and are who may need alternative or additional approaches. And so, estimating someone's risk of a poor outcome. Then the decision makers, like I said before, can weigh the pros and cons and the benefits and potential harms and decide whether they should proceed or not.
Okay. Well, thank you for sharing all of that interesting work from your PhD with us. Now, my understanding is that you're done your PhD. So, what are you up to now?
Yeah, I am currently a postdoctoral researcher in pharmacoepidemiology at UBC's Faculty of Pharmaceutical Sciences, working with the amazing Dr. Mary De Vera. So I'm still in my first year, but my work centers around maternal and neonatal outcomes with perinatal use of arthritis medication. So I'm expanding my experience in epidemiology, women's health, and health outcomes research in general.
Very interesting. Well, we'll have to follow up to see all of the outcomes of this next chapter of your learning. To wrap up the podcast, we always ask our guests one question, which is if you could say only one thing to everyone that will listen to this podcast about your field of research, what would you want them to know?
If there is one thing I want listeners to take away, it is that endometriosis pain is far more complex than we have traditionally treated it. In my research, I was surprised by how strongly anxiety, depression, and pain catastrophizing predicted persistent pain, or just how strongly they were linked or associated with worse outcomes in endometriosis in general. We also see that some patients continue to experience significant pain even after lesions are surgically removed. And that tells us that pain is not always explained by visible disease alone. In fact, for some individuals, the nervous system may become more sensitive over time and amplify pain signals. And when biological, psychological, and neurological factors are all interacting in this way, endometriosis care cannot be a one size fits all scenario. And that is why personalized multidisciplinary approaches matter. And we hope that a tool like the Endometriosis Pain Index can help clinicians and patients together make more informed, individualized decisions about surgical treatment for endometriosis pain.
Okay, well, fantastic. I'm so glad we were able to have you on the podcast today, and I'll get to learn a little bit more about endometriosis and get to learn all about your PhD work, which is incredible. So thank you so much for joining us on the podcast today.
Thank you so much for having me.
Thanks for joining us on the GOSH podcast. To learn more about the Gynecologic Cancer Initiative and our podcast, make sure to check out our website at gynecancerinitiative.ca.